think it's time to start, and I welcome all of you on behalf of Association of Critical Care Nephrology, as well as Reliance Foundation Hospital, the Department of Critical Care Medicine. And obviously, today we all are aware that this is the World Kidney Day, and also the importance of the nephrology in acute care situation, and the collaboration that we always do have between the critical care as well as the clinical nephrology itself. And we think, and obviously, I would expect that our nephrology friend would reciprocate that feeling that the most important friend that we have in our critical care on the ICU arena is the nephrologist. And I can take permission of all the nephrologists present here. The reverse is also true. So we thought that the collaborative process towards excellence, that's a proud process towards excellence. Why not this be the topic of today? And we have a free session. That's why we didn't came up with any structured question answers. We wanted to have a open and free-minded discussion that where are we heading? That means the Quo Vadis. And to take forward the discussion, I would invite Dr. Sudhiranjan Das, who is a senior consultant and renal nephrology specialist in Sir H.N. Reliance Foundation Hospital, who will moderate today's session. And time and again, I will pop up certain controversial questions. Das sir is too good to come up with all the controversial questions, so that responsibility would be mine. But I would also request the others to bring up the questions, whatever in your mind, that how we can have more collaboration between these two to have an optimal outcome of the patient. So over to you, Das sir. And also I would request you to introduce today's esteemed panelist and program director, Professor Dr. Rahul Pandit. Das sir.
Yeah. Okay. Am I audible now?
Yes, sir.
Yeah.
You are.
Okay. Good evening, everybody. It is a welcome session. Basically, on a World Kidney Day, we are celebrating this forum with a certain amount of vigor, and I'm obviously asked by Dr. Arindam to introduce our guest, and obviously the chair of our this program, Critical Care Nephrology, Dr. Rahul Pandit and Dr. Rushi Deshpande. They are part of us, and they are the persons who are the driving force of critical care nephrology. Dr. Rahul Pandit, please welcome aboard, and Dr. Rushi Deshpande. He will be probably joining shortly, or he has joined. I cannot see him. So besides, we have our eminent speakers today, and basically they are the one of the what I can say, best of both worlds. Dr. Professor Dr. Tukaram Jamale, who is the professor and head of the department of KEM Hospital and St. G.S. Medical College, and he has been a friend and guide to us for a long time, and he has been already spearheading the Department of Nephrology for a long time in KEM Hospital, and he has immense research interest in all the fields of nephrology. We'll be discussing shortly about it, what are his achievements and what are his pointers. And the next guest of ours is Professor Dr. Geeta Seth. So she is the head of the department and professor and in Department of Nephrology at JJ Hospital and Grant Medical College, Mumbai. She has been with us. I'm knowing her from the beginning as a student till she has reached this stature of now heading a department and being a professor now. And she has immense amount of research experience as well as in the COVID times, she has helped so much. And she has done so much work during the COVID times. So she will be giving some amount of uh, in, intense uh, talk on that also, if time permits. So the next, I think, Dr. Vishal Saxena, who is a close friend and director of B.L. Kapoor Hospital at New Delhi. And she was a gold medalist in the Banaras Hindu University, after which he did his super specialty, and now he's serving as a director and DNB guide for the hospital itself, for the BL Kapoor. Uh, with that, I think I have the freedom to ask, start the ball rolling. So we have personalities from public hospitals as well as medical colleges, as well as from the private hospitals. So basically, it is like a best of both worlds. So we'll start the discussion with a seminal paper which was published in AJKD in 2013 by Dr. Tukaram. My question to Dr. Tukaram will be that since you have published that literature, which was almost at that point of time quite a significant uh, change happened following that. So your publication, early start versus usual start of hemodialysis in acute kidney injury. So what will be your take uh, at this point, whether it will be a changing concept or changing practice scenario? Dr. Tukaram, for you.
Yes, thank you, Dr. Das and team HN Reliance for having me here today for this interesting session.
Hello.
Am I audible, sir?
Yes, Tukaram, you are clearly audible.
Yes, yes. So as you said, way back in 2011, when we began this work, the only available trial in this area was from a critical care specialist Bowman, who conducted one such trial about early and late initiation. But I think we have moved a lot after initial publication of ours in 2013. So at that time, basically, we had many of our teachers who always used in the conferences used to tell us that we need to start just in time and not early. And there were other people who were of the opinion that as soon as acute kidney injury has set in, kidney function is less than 15 ml per minute, and what is the point of waiting? So we should be beginning as soon as possible. And this always used to be a debate and discussion, but without any data to base points upon. And that's how we undertook the trial in predominantly the community-acquired acute kidney injury. This wasn't really the population that today we see in the critical care units. Nevertheless, our hypothesis was that in population of community-acquired acute kidney injury, earlier start versus the usual start. Usual start, by that we meant that we wait for indications to develop and don't rush to start dialysis just based upon the blood urea nitrogen and creatinine. And then we managed to maintain these patients until urea nitrogen creatinine rose to 8, 9, and we dialyze until then. Whole premise of this strategy was to identify patients who would recover well before the requirement of dialysis. And subsequently, as you can see, the French group of Steffi Gaudry and Didier Depses, and even the START AKI group. All of these people confirm that there is a significant proportion of patients with acute kidney injury, if we can wait for some time, are likely to recover ever without needing a dialysis. Having said that, it doesn't mean that we wait and sleep. Of course, it is a strategy of wait and watch, and we have to be watchful for development of complication, which can arise irrespective of the timing or irrespective of the urea nitrogen and other solute concentrations. And so the watchful waiting done in a team that is trained to identify and pick up the complications early. I think that even as of 2024, literature from critical care areas also will confirm that holds true. I think I will now stop here and wait for any other queries, questions.
So, uh, Dr. Tukaram, since you have initiated that seminal paper, subsequently everybody else also, whatever the publication resurfaced later. So let us say today's world, like you have said that the scenario is a little bit different. That was the community acquired acute kidney injuries. So what is your viewpoints or any papers you have later on compiled to say that the current intensive care strategy, the management pattern, so this holds good for this time frame or not? Early start versus usual start?
Yeah, very well. You may not call it earlier or usual start. Now, people have defined as delayed versus earlier initiation or prophylactic or whenever indicated initiation, whatever you call it. But then I think even from the critical care literature, the people here will agree with me that as of 2024, we do not have any data whatsoever supporting earlier initiation versus delayed initiation. Now, again, here the terminologies can mean different things for different people, but largely it will suffice to say that by delayed initiation, one means that without the development of indication of dialysis, you don't just go by the solute concentration if patient doesn't have any indication. So now here, what indication? Now, especially in the setting of critical care, I think water is the most important uremic toxin that I usually consider as, because there sometimes assessment of this particular toxin can be subject to variation based upon the tools used and so I think that would be one contentious point as to when will you call and what is the accumulation of fluid that is permissible for you before you start on dialysis or wait on diuretics. But apart from that, the latest meta-analysis published after start ACAT trial, probably was the latest publication, would agree with the largely conservative management, at least at the outset. So we don't rush. I think when quotation captures it very succinctly, we are in an emergency. Don't hurry.
Points well taken, Dr. Tukaram. So Dr. Bishal Saxena has joined right now in our seminar itself. So next question to Dr. Bishal Saxena. So in our critical care scenario, so we are facing a situation where there will be requirement of renal replacement therapy with hemodynamic instability. So not enough literature says about the head-to-head trials of CRRT versus SLADE or slow low efficiency dialysis. What should be your thought process regarding these two modalities and when to use what modality? Is it that is what we wanted from you to know.
So thank you very much, Dr. Sudhi, Dr. Rushi, Dr. Purohit, for inviting me in this seminar. So what I would say is that you have to look at the overall condition of the patient. And when these patients are in critical care and with acute kidney injury, definitely they are hemodynamically unstable. They have sepsis background. So a lot of factors, contribute to their kidney involvement. What in my experience and what a lot of papers say is that if you make them, if their hemodynamic is unstable, then if you delay renal replacement therapy, then what happens is you lead the accumulation of toxins, and then metabolic acidosis sets in, your hyperkalemia sets in, dysautonomia sets in, and the hemodynamic instability worsens. So I would, rather than late start of these therapies, I would say that the moment you are feeling that the urine output is getting less, as defined by the Akin criteria, or the creatinine is doubling, or there's setting in of metabolic acidosis, which is leading to increasing dose of inotropes, I would suggest that I would use a renal replacement therapy as early as possible. Because we all know that renal replacement therapy doesn't mean it will going to be lead to patient becoming a CKD dependent patient, right? So that doesn't mean he'll become a dialysis dependent patient. But early initiation of CRRT, especially in these patients who are hemodynamically unstable, it definitely gives us a lot of scope to give them fluids. Very rightly, my preceding doctor said that fluid is the one which is the most important toxin. And there are very less parameters to understand the fluid status of the patient in critically ill patients. You may do IVC assessment, you may put central venous lines, you may use a ICU bed with a weighing measure. But despite all this, they are very inadequate to understand the fluid balance of the patient. And then they undergo pulmonary edema, requiring intubation, ventilation, all these things. So I think the most compatible in these hemodynamically unstable patients with AKI, I would suggest rather early initiation of CRRT would give you leeway to give them fluids if required, would give you leeway to give blood products and nutrition, which is the most important. Actually, to combat sepsis in all these patients, nutrition is sacrosanct. I mean, there's no other supplement other than nutrition to which can hold on to these patients, because they're already depleted by their nutritional status. So if you continue to add supplements to these, if you are able to give antibiotics in full doses, you're able to fight sepsis at a better time. Rather to, hindsight, you feel I should have done it maybe a day or maybe a 2 day before. I would suggest early initiation of renal replacement therapy. Although definitely cost factors do matter, and in India definitely it's an expensive therapy, but ICU stay per se 1 lakh per day in corporate hospitals is more than what a CRRT costs. So I would suggest that early initiation of CRRT in these patients would be better, and would lead to a better outcome. And I've seen this, 2 days, I think Monday, I received a patient who has a decompensated CLD with kidney injury, sepsis with multi-organ dysfunction, and a bleeding PR. The BP was 80/70. And at that point of time, lactates were high, everything was high. And then everybody knows the lactate doesn't get corrected by renal replacement therapy. But we said, as far as blood is concerned, as far as other things are concerned, let us start CRRT. And today, this patient is extubated, and he looks good. So I am a proponent of a early initiation of CRRT rather than wait. Even for, if you see at cytosol therapy, if you look at the timing of cytosol therapy, sepsis, they say it's the timing of cytosol that defines your end result, rather than giving it at a later stage when already proven septicemia is set in. So I'm somebody who's aggressive about using renal replacement therapy in early phases of sepsis rather than waiting, because I understand the cost and everything. But if you can make hemodynamically stable patient, if you can bring out, if you can give him blood products, nutrition, the recovery would be better. That's my take on it.
Okay.
Thanks, Sudhi.
Uh, any preference of CRRT versus SLADE, or you will advocate CRRT as the first line?
See, that will depend on the blood pressures and what all comorbidity I would deal with. But the kind of patient we are talking about right now, acute kidney injury with multi-organ and all those kind of things, I think CRRT would be better, more body compatible, more physiological. And then we can, of course, switch to an alternate day sled or something like that.
And diffusive clearance versus the convective clearance, the advantage of convective clearance, I think.
That we can manipulate in the CRRT therapy also.
Correct. That is what means the in the CRRT itself.
Yeah, so you can maintain the filtration fraction, you can do the pre-dilution, post-dilution removal, you can manage it.
Yeah.
So the handle is also always on the nephrologist, how he manages CRRT. But my only worry at this point of time, the way the critical care is going, I hope we don't have a critical care specialist in here. Do we have?
Yes, yes. Everybody is critical care at this
So,
moment.
so my only worry is that critical care is trying to take over CRRT, which I should think It's a domain of the nephrologist. So let the nephrologist think about how to manage the CRRT and how to manipulate the bag, bicarb, citrate. If they have a coagulopathy, use a citrate kind of CRRT. So I would suggest CRRT initiation at the outset would be better in a hemodynamically unstable patient with acute kidney injury, with sepsis, with multi-organ dysfunction.
Yeah, Besal,
I
we
think Professor Dr. Pandit is, yes,
yeah,
he's very eager to
controversial
answer
topic.
this on that. So Dr.
Um,
Das, I think let's hear to Vishal sir has opened up. I
Controversial
think
topic.
yeah,
yeah,
We
no,
call
not
it the
controversial.
Pandora's box.
Professional,
so I
We
don't
call it
think
professional.
Pandora's
Not
box.
even not even Pandora's box, sir. I would rather say that you have heated up the evening. So I would ask
Yes.
Professor Pandit to respond to it.
look, I think Dr. Vishal, there is no doubt about it that every specialty has its own um, importance in managing a patient in ICU. No doubt about that. And I don't take nephrology as any different. And I really do believe that nephrologists should be an integral part. And that's why we are actually holding this seminar with more than 80% people being intensivists right now. And no, I don't think there is any place where nephrology is being overtaken by critical care as such. But I have difference of opinions on early initiation versus initiation at an appropriate time. I really do feel that we should be initiating the therapy at an appropriate time. I also feel that a lot of times SLED may be sufficient rather than CRRT. And there is enough evidence for that there is no modality which is better over one over the other. And in terms of understanding the intricacies of critical care, there is no doubt about it that the critical care specialist needs to speak with the nephrologist and vice versa when you're planning a CRRT. If in my institute, we have Rishi as well as Dr. Das, both of them speak with us in detail about every aspect of CRRT or SLED before we actually plan up a recipe or a therapy or a treatment plan for that patient. And it is a dynamic plan. It needs to change. And both of us, intensivists as well as nephrologists, work in sync. Only then it can happen. If both of them are working in opposite direction, then it's better to be left to one, whether it's an intensivist or it's a nephrologist. And I come from a background in Australia where completely CRRT driven and completely driven by an intensivist, which we understand that we don't want to do it here. We would love to nephrologists to have their opinion and vice versa, and we'd go together. I honestly don't feel that the message should go out today that CRRT and early initiation of CRRT is necessary. It's not necessary at all. There is no evidence for that at all. And if the CRRT needs to be done, there is obviously a hemodynamic component of the patient which needs to be looked at. And if SLED is to be done, then I think majority of the patients can be worked on SLED if there is a need for dialysis. Early dialysis or late dialysis, high volume dialysis or low volume dialysis, none of them in critical care trials and nephrology trials have actually shown to improve the outcome of the patient. And I'm talking about mortality benefit.
Sir, totally understood, Dr. Pandit. But I would raise this point, early initiation versus late initiation. Again, I and you, both of us cannot give a blanket answer to this question. I mean, we all have to individualize the patient. And as you rightly said, in conjunction with intensivists, we sit together and that's how we decide the modality to be chosen and the risk benefit involved in both the therapies. So I totally agree with that. So I totally agree with what you say, sir. My point was not to take away the debate from intensivist to nephrology or nephrologist. But what I feel is that somewhere, when it comes to a hemodynamically unstable patient who is having a lot of problems and coagulopathy and all these kind of things, I think CRRT gives him that initial 24 hour to 72 hours benefit where he becomes more stable, the antibiotics start acting, you give them full dose antibiotics. See, in SLED, again, there will be your limitation of giving antibiotics in full dose. Whereas in CRRT, you can give a full dose, high dose antibiotic therapy when we talk about septicemia. Especially, I'm talking about in the context of septicemia. So when you talk about high dose antibiotic, full dose antibiotic, recovering that patient from sepsis, then I think initially, if required, I'm not talking about any patient. I don't know any patient that you're talking about or I'm talking about, but I'm talking in general is that we have to both sit together. In conjunction, of course, we need to define the patient's individuality, his requirements of CRRT, his blood pressure, his inotrope requirements, ventilatory requirements, sepsis, everything. But at the end of the day, I always feel that whenever I have done SLED in these patients, somewhere I have given a suboptimal treatment in especially a very hemodynamically unstable patients.
Of course, hemodynamically unstable patient, no doubt about that. I wouldn't even want to, but many times, what is a hemodynamically unstable patient? That needs to be clearly understood by both the nephrologist and the intensive. A couple of
Yeah.
ml of noradrenaline, still volume responsive, and we want to start a dialysis modality because patient is hyperkalemic and not responding to your initial measure. I understand that you may want to use it for some form of this management, but if it is for fluid management, head injury with the need for dialysis, I would never even argue about SLED. I would say CRRT is the only modality because we don't want cerebral edematocyte. Much better fluid management with CRRT. But I think on normal day-to-day, most dialysis which are done are not done on head injury patients, done on septic patients, are done on CKD patients who have now got an acute injury, or who are done on liver patients who come in with multiple organ failure to us. Multi-organ failure, CRRT 48 hours gives you stability. Antibiotics, of course, volume, the CRRT gives you the liberty to give you full doses, in fact, even high doses. But I always say that if a patient comes to you in first 48 hours, do not bother about the side effects of the drug, bother about the effects of the drug, and give them full dosages for first 48 hours, regardless, because that's what's going to save the life of the patient. You need to keep a eye on the creatinine clearance and creatinine at the end of 24 hours. Of course, you manage it. But if I have to give a first dose of colistin on a person whose creatinine is 2.5, and he's just come to me right now, and that's the only drug which is going to help him along with something else, I would not hesitate to give a nephrotoxic drug at that time. But yes, from 24 hours onwards, we would obviously want to look at all aspects. But the first 24 hours is reserved for optimal dosage. Uh, every cell should receive the optimal dosage of the antibiotic, and that should not be limited to giving a CRRT or a SLED or no dialysis for them, for example.
Sir, can you ask you one question?
Yes,
You talked about the antibiotic. How do you assess the fluid status? What is the standard of care of fluid status in
there is no
ICU?
standard of care for fluid status in
So
ICU.
that is exactly the reason.
Multimodality,
When we people have
multimodality
started
approach.
moving above from CVPs to IVC assessments, I
CVP is
mean,
a waste
what
of time.
defines the fluid status?
CVP is a waste of time. IVC assessment done in an unconscious patient or a sedated patient gives you reasonably good
So,
information about
so
the right
that's the
side of the
reason. When
heart.
you say volume responsive or volume non-responsive, how do you determine that, sir?
Let me complete. That's what I'm saying. So along with the right side, if you assess the left side as well, left side by assessing either a stroke volume variation, pulse pressure variation, arterial waveform variation, which is called as a pulse pressure variation also, or you do a aortic VTI on a echo, will give you a very good understanding whether this patient is volume depleted and is volume responsive or not. Just the IVC diameter changing, whether it's a collapsibility index or a distensibility index, does not tell you. All it tells you is that the right heart will accept some more fluid. But whether that fluid is actually responding to an increasing stroke volume and increasing cardiac output or not is the big question. Now, I'll tell you one thing, sir. 90% of our patients don't really require complex amount of hemodynamic assessments. It's only those 10% of the patients where I would not even argue with you. I would say just do CRRT because they are those 10% of the patients. I'm talking about a chunk 90% of the patients in whom the volume responsiveness is not very difficult. You actually know that they are very volume responsive or they are volume depleted and you can give them volume. Again, I would also put a safety margin on there. Every 2 hours of volume resuscitation, do a ultrasound of the lungs and see for B lines. If the B lines are more than one or two in the field which were not there before, stop with your fluid and just concentrate on your vasopressors and other modalities to improve the patient's condition. You've done enough with the fluid. The fluid management is a completely different aspect. And if we do concentrate on that, we will actually take away the thunder of this talk, of this today's discussion anyways. So let's come back to nephrology, sir. And I did not mean to be counteracting what you said. I think a lot of what you said is absolutely true as well. But my message was that let's not just get into a SLED or a CRRT. I think both have got its place. In a hemodynamically unstable patient, I would never argue with the nephrologist. Rishi and Dr. Das are there to witness to that. But I do have my cost consciousness come into picture, even in HN Reliance, that we should not be spending money if we can get away with a sled. Rishi and Das, over to you. I'll be happy to listen right now.
I think
Yeah,
I would
Rishi.
like to step in here, Sudhir.
Yeah.
Yeah. See, I think, this was the whole reason for starting this division of critical care nephrology when we started. And the reason is exactly this, that, we at Reliance, we don't get this divergence between nephrology and critical care because we are always on the same page. And this comes from a lot of things. And one of them is the fact that we talk to each other and not just talk, but also we are able to co-manage the patient so much better uh, by the regular discussions that we host. And uh, I think what's important and what Dr. Rahul was trying to say is that because it is such a changing scenario, that giving a one-stop solution and expecting it to work would not be helpful. It is important that in such a dynamic situation, very regular hourly, 2 hourly assessments are done and decisions taken according to the changing scenario. So, as to the timing and modality of dialysis, there will always be divergence of opinions, even between two nephrologists. And that, I suppose, till unless we are able to really come to some hard evidence-based practice, which is uniform, this is not going to be sorted or solved totally. But in practice, what we are seeing is that even when we say SLED, what do we mean? A strict definition of SLED is a 6 or 8 hours of hemodialysis with a low blood flow rate and with the efficacy which is slightly lower than a regular 4-hour hemodialysis based on the regular dialysate and blood flow. But at Reliance, we are able to offer a 24-hour SLED. Now, how are you going to place a 24-hour SLED against a CRRT when it comes to fluid management? So this whole therapies, and the hybrid therapies, which have become the order of the day. Now we have a HDF machine where we are able to get a filtration fraction, which can take over the function of CVVHDF. So all of these therapies together, I suppose, this is a field which is going to show us a lot of evolution. And every year we will ourselves have different opinions on what would be the best standard of care for a patient at that time.
So, thank you, Dr. Rishi. I think it is a collaborative effort between the critical care and as well as the nephrologist to have the outcome which will be the best suited for the patient. So, Dr. Arindam, you want to comment anything about and the next topic which we can
No,
discuss?
sir, I would rather take a couple of our friends from Indonesia has joined, right?
Yeah.
And they have certain very interesting question on that. One is that how to manage on a resource challenged situation, right? Whether I think they mean a little bit of maybe a resurgence of PD in acute care setting, whether it can be done. So that we have many of the nephrologists, so we can on. And one is that today's question, that how we can address certain issues in a more collaborative functionality. So these two, and then third question I will take on a different platform. I think Vishal sir and Tukaram ji or madam, can you answer the first one? Resource challenge scenario.
Dr. Geeta will be the best person to tell.
I think Geeta ji can initiate.
Resource limited setting, how to give the maximum benefit to the patient.
Good evening, sir, and thank you everyone for this invitation. Sir, you can. I'm audible.
Yeah.
Yes, Geeta, you are audible.
Yes, madam, you're audible.
Sir, in our setup, we are banking on SLED, long duration SLED. We give SLED for 5 hours daily for 5 hours because CRRT is not feasible in most of the patients. So 5 hours duration SLED, or if the patient is very unstable, then we do PD, acute PD.
But Dr. Geeta,
Yes, sir.
at a blood pressure, mean arterial pressure of less than 70, will
Then
PD
we
work?
do not, sir. No.
Then what's the point?
Then we do not.
you Yeah, that's what I'm saying. You see, if you are doing a procedure just for the heck of it, there's no point. We have to achieve the outcomes also. We have to reduce the uremia, the toxins, and everything. If
But
MAP is
the
more less than 70,
CRRT in a government setup is very, very costly, sir.
no, then I think you should go for SLED then rather than
Yeah,
PD
we
in
do
these
sled. We
situations.
do sled.
Yeah, then I agree with you because
We do long
mean arterial.
duration, so we do 5 hours of sled daily. That is what
Yeah,
we do.
that's fine. I agree because we all know the constraints
Yeah.
in government setups, and we all go through that thing in a daily basis. So I totally agree with what you do, but I think PD in these situations will not be viable at all.
Okay.
Especially in patients are, who are not able to shift to the dialysis unit. There we
So
do bedside. Yeah.
for the clarity sake, to the Malaysia delegates who have joined here, just I wanted to tell you that when our blood flow rate in the peritoneal cavity and the peritoneal capillary is at a rate of around 100 ml per minute. So that is a very slow rate, you can say. And whenever there is a hypotension happens due to hemodynamic instability, what happens is the blood flow reduces drastically. So it is basically it is like that the volume of blood flow is reverse of the ratio of R by 4. Means if let us say that the volume or the splanchnic vessels are dilated to X amount, so in case of hemodynamic instability, there will be intense vasospasm in the splanchnic vessels, and if the diameter of the vessels will reduce in size, it will be 1 by R4. So it will almost 2, if it is twice amount has been vasoconstricted, so it will be 16 times the blood flow will reduce. So that's why Dr. Vishal and Dr. Geeta has said that in case of hemodynamically unstable patients, peritoneal dialysis, especially acute peritoneal dialysis, may not be so efficient. So the explanation is like that. So I do agree, points well noted, Dr. Geeta and Dr. Vishal. Arindam, any other points which needs to be discussed?
One thing, a little bit of, I think, antibiotics during renal replacement therapy. A little quick overview that is also being asked by the audience. And yeah, dose adjustment for creatine clearance. So what should we do in patients who are not on CRR on renal replacement therapy and patients on different modalities of RRT itself?
So Geeta, you want to take this question?
Yes, sir. So usually renal replace by the time the patient is on renal replacement, the GFR is almost less than 15. So as per the dosing guidelines, we always taper down the antibiotic to its lower possible. Like if we have to give meropenem, we'll give only maybe 1 gram post dialysis. Or if we have to give piperacillin tazobactam, then it is given 2.25 grams 8 hourly. If you give cholesterol, then it may be just 1 MIU post dialysis. Most of the antibiotics we give after the session is over, and it is usually a OD dosing of the antibiotics in such patients.
Right. Dr. Vishal, you want to add anything
Yeah,
to
so
this?
we already have NHS guidelines which have clearly defined according to the renal function the modification of antibiotics. And that's what we do in our patients. So we modify, as Dr. Geeta rightly said, we modify the dosage of antibiotics as per the GFR. I mean, that's how we do it.
Okay. So I think there are lots of guidelines also says that, and also we have two books which I would suggest to those group of persons who have asked for dose modification. There is a Sanford guide which gives a good idea about antibiotic dosing, where you can in different GFRs, EGFR state, you can see that and verify how much antibiotics to be given. So another
I
one.
would, sir, I would like Dr. Rushi to comment if he is online. I think Rushi sir,
Yes, Arindam.
particularly on CRRT, a little bit of idea to the young critical care people that how the dose should be on a rather on a supranormal dosage, and also a very quick word on augmented renal clearance at times.
Yeah. So thanks, Arindam. See, basically, like we said in sepsis, and Rahul mentioned it before me, that the golden hours are the most important. And at that time, we don't worry about the side effects, but more about the effects. And once the critical 24 hours have passed, you start and look at the bigger picture and start dose adjusting as per the effective clearance. Now, when you're talking about renal clearance, you have no choice but to do a timed creatinine clearance, which we are doing now. So a 1 hour estimation of UV upon P, and kind of extrapolating it to 24 hours, and that remains the best measurement of GFRs in the ICUs. When you speak about clearance, we should always remember that we have to calculate the residual renal clearance along with the dialysis clearance to come to an effective clearance when you're dose adjusting, and this would avoid underdosing the patients, particularly for critical antibiotics. In terms of dose adjustments, there are enough guidelines to go by the clearance. For every single drug, there is a clear guideline available as to how to give it. And my only take home is A, do not forget to add the residual renal clearance. B, based on your modality of therapy, uh, adjust the doses in such a way that you have optimized the usage of the antibiotic, minimize the wastage. Like, conventionally, whenever we used to do only hemo or SLED, we used to always give antibiotics, at the end, and then expect it so that it remains in the circulation for the longest period of time possible, and you get the best cost effective treatment also. That being said, now we have grown to a point where we say, okay, no, you give one dose before, and at the end of the session again give it. While on CRRT, we just give it as if the GFR is between 30 and 60, and just continue with the antibiotic round the clock at that dosage. So every drug is important, and also, onconephrology and dialysis, that is another thing that we always address in our institute, because we have a lot of oncology and hepatology patients also. And there, the drug dosing is again much more complicated than just in pure AKI.
Thank you.
Also
Just to add,
Geeta.
just wanted
See,
to add that
Geeta, go.
as you said, sir, this has to be a dynamic thing. You have to keep on changing your doses.
Yes,
Every day, the dose will change in case of AKI. So that point
absolutely
is
correct.
well taken, sir.
Absolutely. Totally in agreement.
just to add to what Dr. Rushi said, my thoughts is that the antibiotic, whenever we are utilizing, we have to also see how much is the volume of distribution. And another one is whether it is a concentration dependent or a time dependent. These two factors, plus whether it is a water soluble or it is a protein bound agent, that also takes very important pointers towards how much your dose has to be given as a loading dose, or how much concentration you want to give or post renal replacement therapy. So all those are critical issues. I think better to follow the guidelines which has been already the pharmacokinetics and pharmacodynamics was performed in uh, uh, those scenarios, and they have formulated a guideline to say that this is the amount of uh, uh, concentration of antibiotics you have to use in those group of patients. Uh, I think, Arindam, we have couple of questions from Indonesia also. One is, uh, Miss Dr. Alanda from Indonesia. So the question is, I want to ask a question. What are the parameters of discontinuing CRRT therapy in patients in ICU? And can this therapy be replaced with hemodialysis when it can be substituted? Anybody can comment on that? So basically discontinuing CRRT therapy. Vishal, you want to take?
Yeah, I think once you start seeing an improvement in the patient hemodynamic, the most important factor would be a hemodynamic factor. If the hemodynamic stability starts increasing, the inotropic requirements start decreasing. And suppose your CRRT is clotting, because coagulopathy also happens. You might be using a citrate CRRT. It depends what modality you're using. So if your hemodynamic starts improving, the patient's overall status starts improving, then of course, once your CRRT filter clots, I see CRRT is a very expensive therapy for Indians. By and large, whether we're sitting in HN Reliance, whether I'm sitting in Max group, it still is an expensive therapy. So we need to take the constraint of financial constraint that the patient bears of these therapies. So I totally agree that it's an expensive therapy. But most important above all these things is the life of the patient. So once I see that hemodynamics is stabilizing, the inotropic requirements is decreasing, and my CRT clot. See, once you have started it, then you can continue till the time it doesn't clot. Okay, but if you feel that there's no need for the hemodynamics are stabilizing, your inotropic requirements are getting better, then you can discontinue and go for a sled alternate day, or you can do that. So this can be done. But again, I cannot give a blanket answer on that. It has to be a tailor-made, individual patient consensed answer. So I have no answer to that.
Rushi, do you want to give some inputs on that?
Yeah, so I suppose one of the points is, when do you stop dialysis? And again, the answer is, uh, once you start seeing renal recovery and you think that the patient can do without dialysis and continue to recover, that is when you start, tailoring down dialysis, like Vishal was trying to explain. It's impossible to give a blanket answer. It's always going to be a every patient based scenario in deciding what to do with the dialysis for that particular patient. General guidelines would be, if the patient is improving, coming off inotropes, more stable hemodynamically, switch to a more cost effective way of dialysis, be it SLED or be it be regular hemodialysis. And if the patient is showing enough recovery and trying, he's more diuretic responsive, try and increase the intervals between dialysis and effectively try and stop dialysis whenever the indication for dialysis is finished.
Rushi, a question from my side for you.
Yeah.
CRRT is a convective waste clearance.
Yeah.
And when hemodynamically stability we get to achieve, whether in current scenario I am talking about, current means, although hemodialysis, we know that it is available all the time, but recent insertions of hemodiafiltration into our practice. So do you want to change from CRRTs to hemodiafiltration rather than hemodialysis?
So, Dr. Sudhir, thanks for the question. I think you're just trying to bring out the important point that convective clearance is getting more and more relevance in our practice today, with the evidence coming up. But that being said, it is still not something that the whole world has accepted as a standard of care, and it is still work in progress. Not all units are equipped with the HDF machine, and step down from CRRT to HDF is still something desirable but not universally practiced. That filtration is always been like a mystery thing, right from the first trial of Ronco, where he showed us that increasing, from 15 to 35, there is a mortality benefit, and that's how all of us switched over to diafiltration. But because of the cost involved in providing CVVHF, we have always practiced CVVHDF and never really done CVVHF. It's now only because now the machines are able to generate the dialysate online that HDF is becoming a reality in today's practice. So once it becomes more cost effective, or if it shows a clear-cut benefit, which is like a standard of care, then I suppose it will be universal practice. Till then, again, it is going to be individual preferences and something that people will keep choosing between.
Correct.
I
Thank
think
you
Dr.
so much.
Rushi very well pointed out that point. What you were trying to bring in, Sudhir, was HDF versus hemodialysis. That's another debate that keeps on happening in nephrology, and how much. So, 21 liters, 23 liters, and as Dr. Rushi said, but again, the consensus has not been received as of for now. So, it's still an evolving trend. But Dr. Rushi very well pointed out the need and the requirement of HDF versus HDF, availability, cost, online filtration, RO clearance, and everything. I think he rightly said it. I agree with him totally.
Thanks,
Okay.
Vishal.
The another question, Arindam, should I continue or you want to intervene?
No, sir, please.
Okay. So there is another couple of questions from Indonesia. Uh, I thank Indonesian candidates who have joined with us actually. And if you want to learn more, actually, we have a critical care nephrology conference, almost seminar, on 30th and 31st of March, which will be whole day program. And uh, I think if anybody is interested, then they can join in also. So
Send me
this is a
tickets and I'll
message.
come with my family.
Now,
And I'll stay with you only.
Yes.
also to people from Mumbai and also within India itself. So 30 and 31st, we will have a 1.5 day program. So Geeta madam and Tukaram sir, Vishal sir, if you're, and it's a complimentary registration program itself. So if any one of your students, postdoctoral fellows want to join, yet we have not decided whether it could be also online, but I think we should do an online supplementary program along with it. But as of now, it is offline, and I would be sending you the details. And if you allow us, we will include you into the group of critical care nephrology. Almost every Thursday, we are meeting for an hour and discussing certain relevant issues on nephrology as well as in acute care setting.
Thank you
So
so
we
much,
will.
Ananda. I would love to be a part of it. Thank you so much.
Thank you, sir. Das sir, please continue.
Yeah. So the next question is from Juan Sipita from Indonesia. In CKD patients with sepsis condition, should we prefer CRRT instead of regular dialysis? Geeta, you can take on this. CKD patient with sepsis condition.
Patient is
Or-
hemodynamically stable, sir. I would continue with dialysis.
Okay. And
Yeah.
Dr. Tukaram, you have any difference of opinion or
Yeah,
any?
I largely agree with Dr. Pandit's and Dr. Geeta's opinion and Dr. Rishi's as well that more than watertight division between the modalities, it will be dictated by various patient-related and your setting-related factors. But as of the scientific evidence goes, there is no advantage of having CRRT over intermittent or SLED. But as Dr. Pandit said rightly, that in patients who are at risk of cerebral edema, like one with head injury or hepatic encephalopathy, that is the reason that someone can choose preferentially the CRRT because it will decrease the risk of worsening cerebral edema. Apart from that, I think it is up to the availability, available expertise, and the resources. And I don't think there is any need to feel guilty about that you are not having access to CRRT because as of now, scientific evidence supports use of SLADE or IHD in this setting. Nevertheless, there is a definite patient population who will be benefited and suitable most for CRRT.
And we are doing it every day. Like,
Correct.
it is, yeah.
So
Despite
it
of,
is
yeah. And we have not found any difference. Whatever we have.
Thank you, experts. Another question from Indonesia, Dr. Raras. I want to ask if we met the patient with encephalopathy uremicum and had a history of prolonged coagulation factor, prolonged ventilation, how's the management of the patient? I think Arindam and Dr. Pandit will be able to
I think let's
give
take the
justice.
question. I'll ask Arindam to address to her separately on an email or something.
Correct.
This will be too much to get into. But if you want to talk about uremic encephalopathy, I think that's a nice way to sort of address that first part of it. That's what she's asking, uremic encephalopathy. Prolonged ventilation could be a part of the uremic encephalopathy, unfortunately. But if anybody wants to talk about uremic encephalopathy, please go ahead.
Okay, that can be addressed at a later period of time. I think we can touch upon with the candidate, the person with Dr. Raras, and later on we can discuss about that at length. Arindam, anything more?
Sorry, I will ask Dr. Pandit a last question because I think we all had a more view from the viewpoint from the nephrologist itself. So, Dr. Pandit, one interesting question from myself:
Sure.
that what should we strategize in our day in critical care itself, so that we have least infliction on kidneys, that we can prevent a little bit of AKI. So this concept, I'm sure that you can get my question for where it is coming from, that
Yes.
we have refined ourselves, for example, in ventilatory strategies, so that there are less amount of biophysical injury and then eventually lesser amount of cytokine release, which eventually had a crosstalk with kidneys and reduce that part. So what are the other strategies, right? Be it your ventilation strategies and other strategies where we can minimize infliction on the kidneys itself.
So if I was to answer your question and formulate your question, in fact, not answer, first formulate your question, you would want an answer similar to a lung protective strategy. So you would want a kidney protective strategy to go. Is that what you are trying to say? So you are going to ventilate, but you want to protect the lungs. You don't want to cause further harm. So you want to treat a patient who is hypotensive. You want to treat a patient who may have a kidney injury, acute kidney injury. Whether they have a background kidney injury or not, chronic kidney injury or not, that's a completely different question altogether. But I agree that it is a very important balance that we often forget. We often forget to address and timely intervene to actually have a kidney protective strategy. And the kidney protective strategy for most people is about avoiding nephrotoxic drugs. That's not what kidney protective strategy. That's just one aspect of it. To use the kidney protective nephrotoxic drugs in a smart way, you may have to use them sometimes. You may have to avoid them at some stages. But I think what we often forget about is the volume status of the patient. We also forget about individualizing blood pressure targets for these patients. And we try to fit one size fits all mean arterial pressure of 65, where we know now that while the sepsis trials have not shown to make a mortality benefit, certainly the incidence of renal replacement therapies have changed in patients in whom higher blood pressure targets were used. The incidence was much lower. There's still a lot of use of fluids which may harm kidney. So we are still not clear about why some of the anesthesiologists are still using starches and gelatins in their practice. That's one thing which we are not really comfortable using in ICU at all, and there is enough evidence for that. We are also not very clear about using some of the vasopressors or for example inotropes early on. And then there is this big debate about what should be our strategy to use nephrotoxic drugs, whether we should be using them, especially antibiotics. I'm talking about pain relief and stuff. You have got enough alternative, but you may be sometimes bound to use some antibiotics, which may be life-saving in one hand, at the same time may be nephrotoxic in the other hand. We also don't look at abdominal pressures and medical intra-abdominal hypertension or surgical intra-abdominal hypertension, which plays a very big role in your kidney perfusion. And quite often we actually forget about that. We think 20 millimeters of mercury pressure intra-abdominal hypertension is the cutoff level. But if you go and look at the World Federation of Intra-Abdominal Hypertension, the definition, for medical patients it is 12, and for surgical patients it is 15, which is the intra-abdominal hypertension definition. And if it crosses beyond that, you are actually looking at hypoperfusion of the kidney. So I think these are some of the simple thoughts which come across my mind. I think there is no harm in having a strategy. In fact, this group is an elite group. You've got good nephrologists and intensivists here. You can actually come out with a small white paper and send it for publication. Kidney protective resuscitation or treatment. I think that's a very intelligent question which you have asked, Dr. Arindam, and it will require a little bit of deep diving into a lot of aspects which we do in critical care before we come into that. I hope I'm able to at least throw some light and direction towards what you were wanting to ask.
Thank you, sir. And I think everyone got a overview of it. Maybe we will definitely have a separate session on that, and we'll start the deep diving in. That's, sir, over to you.
Yeah, I think what has started at this moment is kidney protection, obviously nephro protection. So what we see in our clinical practice basically is chronic kidney disease patients who are having a significant residual renal function. So and when they come to the critical care unit, so we tend to try to preserve that residual renal function. So that why it is so important is that whatever modality we are talking about, renal replacement therapy in long run and future, we are unable to take out the middle molecules, and which are a significant molecules which are in later stage will cause more harm in the cardiovascular and the morbidity and mortality. So that way, there is a question from Indonesia, Dr. Ehsan, that what are the strategies nephrologists use to optimize the renal function and prevent further deterioration in patients with pre-existing chronic kidney disease admitted to the intensive care unit? So, Dr. Tukaram?
Yes. Yeah, it's a very interesting question indeed. And Dr. Pandit just briefly dwelt upon this very important point that I think there is enough literature from the not directly but indirect literature in the critical care area also, that targeting a higher MAP in patients with chronic hypertension, especially not overall critical care population, but patients with background hypertension, and especially with those with chronic kidney disease, invariably they have hypertension as a comorbidity. So their targeting higher MAP is indeed a protective strategy, clearly reflected in the lower incidence of acute kidney injury when these patients were targeted to higher MAP. So higher MAP, by that I mean individualizing it to the patient's usual or pre-existing blood pressure. Somebody who is requiring 3 and 4 and 5 antihypertensive at background, you may want to go as close to his usual blood pressure as possible when targeting his MAP. This was one point I wanted to reiterate with what Dr. Pandit has brought up. Second point I would like to make here was how to protect the kidneys in critical care setting. Now, biomarkers have been talked a lot in nephrology without clearly getting anywhere. We still continue to rely on creatinine, and there is no good place for these biomarkers in routine practice currently. But I think there is an exception here, a setting where we know that patient is on nephrotoxic medications, especially aminoglycoside, because many times we are cornered to use the drugs because that is the only antibiotic we are dealing with, some MDR, Klebsiella, and so you are using aminoglycosides, and in those patients, probably this is not evidence that I'm talking about, but it makes sense to me that we measure or monitor their kidney function with parameters which are better than creatinine. I see that place for biomarkers in intensive care unit. I think these are the 2 points I wanted to make.
And what about the contrast?
Dr. Tukaram, can I ask you one question?
Yes, sir. Go ahead.
And of course, all the other nephrologists. A lot of nephrologists are, use nephrosterol as a renal protective thing. What is the evidence for that?
Please forget it, sir.
Madam
Please
nodding,
forget.
nodding their head
Please.
against it. But I want to know, I mean, why is so much of love on nephrosterol for nephrologists? I'm happy
I think, sir.
he doesn't have it, Das doesn't have it, but there are nephrologists who have it.
Yeah, I as clueless as you, sir.
Okay.
No. Just
There
I
is
want to add.
there is a 2C level evidence of N-acetylcysteine.
Okay,
what
so
I have
let's
come
to
across.
see.
But
To
it
see.
is not. It's 2C. The level of evidence is.
So what? Just I want to add to Dr. Rahul's question. If it is nephrosterol, you are talking about keto analogs. Nephrosterol
Yeah, probably
is
that's
keto
what sir
analogs.
meant. That's what probably sir meant. I think Dr. Das, we have to now answer and satisfy.
Yeah. So there are a couple of Italian trials which gave us some insight that keto analogs, if you are utilizing basically the place of keto analogs in chronic kidney disease or the protein restriction, that has been thoroughly investigated. So protein restriction, we don't mean that the whatever protein you are taking, if it is excess of that, whatever the recommendation is, which is around 0.6 grams per kg of body weight, ideal body weight. So it has been seen that when you are giving higher amount of protein, especially in Western diet, almost they take around 1.2 to 1.4 grams per kg of body weight of protein. So then there is an increased glomerular capillary pressure, and that causes in long-term affection over the single glomerulus, causing sclerosis. So that has been tried in animal models, and it has been documented in MDRD study also. So, however, to counter that, what they try to do is that if we increase the protein intake to such an extent where the urea will not be generated much, it is basically non-urea uh, 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 formation by the liver, so that the uremic milieu will be not created. So they reduce the protein intake to almost half and add a keto analogs, and that way you are just prolonging the, or you cannot say that whether it is affecting the progression of renal disease. Some of the Italian studies, they said that we are delaying the progression of renal disease, but symptoms are a little bit better, definitely. And there are a couple of articles which are saying very low protein diet, BLPD, that is very low protein diet, where we reduce the protein intake to around 0.3 grams per kg of body weight and add keto analogs to maximize it, so that urea will not be generated and they will not be having symptoms. That is the advantage of keto analogs.
But Sudhir, can I say something?
Yeah.
I suppose all this discussion is relevant only to CKD in the outpatient. I think what Rahul must not be asking about keto analogs in ICU. Nobody would prescribe patients keto analogs in an ICU setting.
That is.
I suppose when it comes to protein supplementation, nephrosterol or aminosterol or all those are basically a protein supplementation along with some calories to a patient who is not yet on TPN but needs an extra alimentation, Rahul, if that is what you wanted to say. And as to what it gives, I mean, it gives you 25 to 30 grams of protein, and particularly it includes the essential amino acids which are required in this scenario.
So I sort of didn't mean that way. The question came in regards to the nephroprotective attitude which has been.
No, nephrosterol has no nephroprotective
So that's what I'm
effect at
trying
all.
to say, that If
No,
you
no, no.
use it as an amino acid, so first of all, there is no role for amino acids to be given as well. You either give
Exactly.
or you give enteral nutrition. Um, so that's a completely different debate. I was actually
Exactly.
talking about some nephrologists talking it. दे दो किडनी चलेगा किडनी अच्छा रहेगा.
No, no, no. I think it
That
is just a
is
very good
completely
trading or marketing
non-evidence
gimmick,
based.
You put the name nephro and it makes sounds like, it's something for the kidney. More than that, I don't think it will have any water.
I agree.
And what Tukaram said was very good that, just forget it. He gave the best answer as
Yeah.
soon as you gave the question.
I remain clueless, so I think clueless is better not to know something than to know half.
Exactly. No, Dr. Tukaram was very, very clear when he said, let it go, sir. Let go of the question. Sure. I suppose it has been an excellent discussion. Arindam, thank you so much for arranging such a beautiful talk on World Kidney Day. And a big thanks to Dr. Tukaram, Dr. Geeta, Dr. Vishal
Yes, sir.
Saxena for coming and attending this session with all of us and making it really lively and really worthwhile for all of us here. So, like Anindam mentioned, we at RFH for the last 2 years, we are running this critical care nephrology course, which is a teaching course for in-house candidates. So we are opening it to people who are not part of RFH also, and we would love it if your residents are able to join whenever they want to. And, uh, we are having two fellows, kind of, in-house fellowship programs for critical care nephrology. It is a 1 year fellowship program. We have been running it for the last 2 years now. This is the third year. And Arindam is the backbone of the program, as you must have realized by now. And thank you so much for arranging this today, Arindam.
Sir,
Thank you
also
so much, sir.
kindly invite for the 30th and 31st program.
Yes, definitely. I think you already extended the invitation. I will be calling all the three of them personally as well to invite them for the program. And all, so I'll do that at a personal level in the once this meeting is over.
Fair enough. Pandit
Thank
sir,
you.
some closing remarks. Sir, unmute, sir.
Thank you very much, Dr. Arindam, Dr. Rishi, Dr. Das, and Dr. Geeta, Dr. Tukaram, Dr. Vishal. I think these kind of collaborative discussions, especially surrounding only one or two topics, are very, very important. And I believe that it only adds on to the whole knowledge pool, makes our juniors more wiser, and makes us think also that what are we actually talking about when we are speaking up to a forum as such an on an impromptu discussion about a particular evidence or a particular practice which we believe so much passionately into it, or we believe that it is not in the right spirit to do it. But many times we see that there are gray areas, and where we have to just agree to disagree, or sometimes we have to just accept it that this is the age-old practice and there would not be any evidence generated in near future, and we may have to continue that way. But I think the world is progressive. A lot of things are evidence-based, and as long as we practice evidence-based medicine, I think that is absolutely fine. A little bit of variation is going to happen, which we have to accept that as a human nature. Thank you very much, Arindam, for the whole discussion. It was lovely.
Thank you, and we will come back very soon. We have a lot of other topics to cover. We were looking into the intervention radiology and radiology in critical nephrology. So onconephrology, we have already started discussion on the onconephrology itself. So a lot of interesting, then your nephrology and predictive analysis, AI in nephrology, a lot of different topics would be covering, and we would invite all of you and our friends from Indonesia who have joined. Please feel free to join, because this is a complimentary session itself, and we do it every Thursday. So we'll see you soon on that. And again, once again, we invite you for the 30th and 31st annual conference of critical care nephrology, which will be held offline in Reliance Foundation Hospital. So good night once again, and wish you all a happy and successful World Kidney Day for today. Thank you.
Thank you very much. Bye-bye.